All right, well, welcome everybody for this is the second session of Conversations in Health, Global to Local. And thanks everyone for coming on tonight, which I know is an administrative Monday, so I appreciate everybody being here for this. And we have a terrific guest speaker, Professor Timothy, well, I should say Professor Emeritus Timothy Westmoreland from our law school, who's had an extraordinary career on Capitol Hill. He's literally been involved in the writing of the Affordable Care Act, meant too much time. We both spent too much time on the Clinton Health Reform Plan, and as we'll hear a little bit tonight, he was the staffer involved in the first HIV hearings on Capitol Hill, and many other public health issues in between. He's had an amazing career on that looks at that how law and public policy in the messy business of politics and the messy business of how legislatures work, how we make policy and make decisions. Well, Professor, we are thrilled to have you here. And as also is our tradition, we like to start at the beginning. So I thought if you would share with our group, you have a sense here, we've got students, undergraduate students in health, particularly global health, but also a range of health majors. I guess if you could take us a little bit back to where it all started in the Blue Ridge Mountains, but no, just a little bit about how you, when you got to college, what you were thinking about, where you came from, what brought you there, and then your career as you went forward.
My name's Tim Westmoreland. I'm originally from the Blue Ridge Mountains of North Carolina. I grew up 15 miles outside of a town of 500 people. There was one high school in my county. And, to get to the education stuff, which we usually do, I then went from high school in Boone, North Carolina, to college at Duke in North Carolina, and then to the law school at Yale. And then I came to Washington after that, after I went to law school. I started in this, and I told John, he said, we'll just go back to college. And I said, no, we should go back a little further. When I was a little kid in elementary school, my father was the chaplain in a tuberculosis sanatorium. And my mother was a laboratory technician in the tuberculosis sanatorium. And this was at a time when tuberculosis was not fully curable. And I ate every Sunday lunch in the employee cafeteria in a TB hospital when I was a little kid. And I got a sense from this of, what are infectious diseases? I used to skin test positive for TB. I don't anymore. And also what it is for poor people to end up in public hospitals and maybe for life. I mean, some people were essentially incarcerated in a tuberculosis hospital there until they died. And so I started with the idea, with a feeling from my parents that I'm an only child also. The feeling from my parents that, people are in need, and you should do something about that. And my parents were actually quite religious also. And so, they sort of said, this is your obligation to do something about that. So when I went off to college, well, first of all, I should say that my family assumed that I was going to be a minister also. That for a lot of reasons, that wasn't in the cards. But when I went off to college, I thought that I would be a clinical psychologist. And that I would work on mental health and what we at that time called mental retardation issues, developmental disability issues. And when I got there, you guys won't know this, John may remember this, to be a clinical psychologist at the time, now we're talking about the 1970s now, to get a PhD, you had to do research work. You had to get a PhD that was essentially hard science in psychology. So I spent a while in my senior year doing the experiments with rats and pigeons and screaming babies and things like that, and then a bunch of psych statistics and stuff. And I said, I hate this. I'm really not interested in this. So what can I do that will sort of get to the idea of people who are in need, and it's your obligation to help, but doesn't put me in the position of having to deal with rats and mazes. Well, not literally.
Exactly.
Rats and
I was going to
mazes.
say, there's similarities.
Yeah, there are. So I went off to law school saying that I was interested in law and health. And I'm older than John is, so he maybe not doesn't remember this. But at the time that I was applying and saying I'm interested in law and health, people assumed that what I meant was, bringing cases against doctors for medical malpractice. That was law and health at the time. And I said, no, I'm really not interested in that. It's too much like being a lawyer. I'm interested in distributional economics, distributional ethics. I'm interested in how you get healthcare to poor people. I'm interested in biomedical ethics and things like that. And as it happens, I don't know if it's, the Yale Law School is extremely flexible in what they let you count. So I took a course in the medical school. I took a course in the divinity school in medical ethics. I took a course in the nursing school. I took a couple of courses in the business school, and all about health. But at the end of it, the law school accepted those credits. And as I've joked before, it would have been per se malpractice for me to practice practice law. I mean, I never took property, so I know nothing. I've never taken a bar exam. I couldn't pass a bar exam, but I knew a whole lot about health policy at that point. And suddenly, during that time that I was in law school, other people started being interested in health policy. You may or may not know that between second and third years in law school, law students do a summer associate job where they work in law firms and get a taste for it, and the law firm gets a taste for them. And I looked around for health law firms, and I couldn't find any on the East Coast. There was one in Los Angeles, a little boutique firm that was beginning to do that practice. So I went to LA and I worked there. And I learned a lot from those people about the real practice of health law. But I also said, once again, this isn't for me. These people are representing pharmaceutical companies and insurance companies. And, as far as I was concerned, the views I express are my own. They should not be construed to be those of Georgetown University, but the people who were screwing up healthcare. And I didn't want to do that. But I learned a lot. And so I came to Washington looking to try to do, it was a little bit of a frontier. There weren't people doing health law, but I wanted to do good guy healthcare law. And I went to work for the House of Representatives for the Subcommittee on Health and the Environment, which had a new chairman who was assembling a new staff at that point. And, it was a roulette spin. It was once in a blue moon that you can get a job straight out of law school working for a committee, and for a great guy. And I worked there for 15 years, and I was not the longest person working there. And if you don't know already, Hill jobs are really short tenure. People stay there for 2 or 3 years and then move on to other things, and I stayed for 15. I would have stayed longer, but when the Republicans took over the House with Newt Gingrich, they fired most of the Democrats. So I went to work there, and that's sort of my path, is that I started eating lunch, Sunday lunch in an employee cafeteria in the TB hospital, and I ended up working for the Congress on public health issues. And one of my first statutes that I worked on, and it became law, and I helped preserve it during the savagery of the Reagan administration, was Centers for Disease Control grants for tuberculosis control. So it sort of led to the right place at that point. Is that a good...
That's an excellent start. No. And one question lots of undergraduates have here at Georgetown, probably at other schools too, is you think of a law degree, one track is you're going to practice law.
Right.
When you went in, it seemed like you pretty much knew from the beginning that you weren't on a traditional career path. And now that you've taught law students for many years,
Right.
what's your thinking about going to law school for a broad, well, nice thing about a law degree is you can use it for a lot of purposes.
Yep.
We're both lawyers who don't practice law.
Right. I never intended to be a real lawyer, to practice law, and I never took a bar exam. So, and I never took a lot of the courses that are fundamental to most people's practice of law. Um, I think even today, certainly at that point, I think a JD is one of the most flexible degrees in careers. Um, you can go to work. There are a lot of places that'll say they want an MBA or they want somebody with a graduate degree in health policy or something, or master's in public policy or something like that. But they all are willing to accept a JD as well, in lieu of those kinds of things. I shouldn't say all, but I'd say most, remarkably. And the other thing about it is, as opposed to, remember, I didn't go for a PhD, as opposed to a PhD, it's only a 3-year degree. And lots of people spend 7 or 8 years trying to get their PhD, or much longer to get their medical degree. And the law degree gets you in the door for most of the same jobs that a PhD or, well, maybe not the practice of medicine, but people who do health policy as medical practitioners. So it's practical too. You get 3 years of graduate work, and you get the flexibility of. And the other thing I'd say is, it's an open secret. I don't know why it's still true. Other people who don't have a law degree sort of believe that people who've been to law school know a lot of things that we don't know. There's a sort of mystery about it that, you've been to law school, you understand the law. No, I understand reference works now. I know how to find the law, but I don't memorize the U.S. Code or the Code of Federal Regulations. I don't know this stuff. But people continue to believe that I know these things cold because I've once worked in that area, and when in truth, what I know is how to do the research to find what's going on in that area. So that's my view. But you're a lawyer that doesn't practice. What do you think?
No, I actually, what you said is what I typically say to the students ask. I don't, I think the trade-off, the one big difference between when I went to law school and when I went to law school, I didn't intend to practice in any sort of traditional sense. And I too, after I clerked for a judge after I got out of law school.
That's another mark of respectability that I don't have.
I did take the bar exam. I felt like I owed it to my parents to take the bar exam, but I knew where I was going. And I too got lucky to come to Washington at a time when a member, in this case a senator, was taking over a committee and was assembling a new staff. That does not happen very often. When you walk in, hiring 5 or 6 staff. So I was literally right place at the right time. I think the biggest difference is that law degrees cost more now than they did, both in real terms and in the 3 years is definitely a better deal than going to get a PhD unless that's what you want to do. But I think it's just expensive, so you just have to think through the trade-off. But it is a very flexible degree. I know people who with a JD, you can walk into almost any sector of our economy and be relevant because of the skills you learn as a lawyer. So it's the upside. Now you don't have that expertise you get from being a scientist or a biomedical researcher, but you can walk in and work in a lot of, especially if your interest is on the policy domain.
Yeah.
It's a great door opener.
And I get a lot of people coming to me and saying, should I take a master's in public policy also, since Georgetown has such a good master's in public policy, and other people take that to do health policy. And sure, you learn there are a lot of really good people there, but I think the one core element that public policy students get that law students don't necessarily get that is important is some knowledge of statistics. And in public health school, you'd learn it as epidemiology. But I had, like I said, psych stats as an undergraduate, although I had to go back and review a lot of that stuff by then. But you need to be able to, you don't need to be able to generate the statistics. You just need to be able to read them and have some understanding of what they mean. Because health policy is governed by numbers in a lot of ways. And if you can't, you don't need to know a one-tailed versus a two-tailed chi-square test. You really don't need that. But you do need to know the difference between a median and a mean. And you do need to be able to read the numbers and say, well, that's not a large enough sample to be significant. But you can get that with one semester as an elective in the law school, or you can go get a public policy degree and learn lots of other relevant things at the same time. But law schools generally don't require you to do any of the math or statistics stuff.
And again, in sort of the spirit of, when people ask me what is the most relevant class I took as an undergraduate here, there's no doubt it was the 2 semesters of statistics that I had to take to be an econ major. I mean, the economics changes and the theories change over time, but those stats skills really are incredibly useful. And I like to think of it as it helps you be, I can't generate any of it, as you say, but I think you can be a decent consumer of
Yeah.
it. And that's really the goal. Because as lawyers, traffic in evidence. Like our goal is to be able to how do you generate an argument with evidence? So you know statistics enough to be a decent consumer and to evaluate what you're looking at, but not to be the producer of it.
That's exactly what I mean, is that you can read a piece of evidence or read a study or and be able to say, well, this is reasonable or this is not, and those kinds of things. And since I ended up moving forward here,
Yes.
accidentally being the lead staffer on public health issues for the House of Representatives for 10, 12 years. Centers for Disease Control, Food and Drug Administration, NIH, those kinds of things. I needed to be able to read these studies and these statistics and to, nobody expected me to create them, but I needed to be able to read them and say, well, then that would point in this direction, or we need more information. And so I say, and I don't know if it still does or not, but the health school used to have a course that started out as epidemiology for lawyers.
I think we still do, but I don't know if the person, John Kramer taught it, but I don't know if he's still teaching. But that's something we can check out. He's a professor, as many of you know, in the School of Health. So,
And he used to be at the law school.
Yep.
And, you know, we talked for a long time about, I don't know if you know the phrase, but mass torts, when really bad things happen to a whole lot of people, like this train derailment or something like that. Mass torts is gonna, the lawsuits generated by that for negligence and injury and damages and all that kind of stuff, a lot of it's gonna boil down to epidemiology. So lawyers need, health lawyers, I think, if you're really even going into practice, much less into policy, I think need to be able to read that stuff.
so let's pivot back to you and your 12 to 15 years as the lead health staffer in the U.S. House, and because of the role in this committee. A little bit, obviously, of the three agencies you referenced, CDC, NIH, you know, the big parts of HHS. But what exactly did you do in that role? Working, and you work for Congressman Waxman, who was an incredibly well-regarded legislator. And I get, this is no disrespect to the 435 members of the House at any given moment in time. Many of them are not great legislators. They don't have careers that result in extraordinary accomplishments. Congressman Waxman is one of those people that has an incredible record.
Right.
What role did you play in that process?
Well, and forgive me, some of you, I'm sure, have worked in or around the Congress, so I'm telling you things you already know. But the committee staff work at the behest of the chairman, the chair, and follow his or her direction and what they want to pursue. But the committee staff also work for the entirety of the committee in some fashion. So by having let's take CDC, for example, the CDC portfolio assigned to me, and that's sort of the way that I think most committees work is, if you're a personal staff person working for an individual congressperson or senator, then you may have to deal with a million things at the same time, but committee staff get the relative luxury of being able to get a little bit of a specialty so that we can actually come to know an agency or come to know a group of policies. So I'll just take an early example that I worked on when Ronald Reagan became president. Everything in the public health service and at HHS was under attack. I actually don't think most of it was purposeful about the programs. They just wanted to stop spending money, period. They wanted to cut taxes and they wanted to stop spending money. And you know, one of the first things that was proposed in my realm was effectively to cut childhood immunization programs in half at CDC. And I just, what am I going to say? cut childhood immunizations? Polio vaccine? We've just come through a period where COVID vaccines have made it controversial, but it used to be, American and mom and apple pie. Childhood immunizations is what you really want to do. And so my job at that point was to try to generate support for continuing and indeed expanding the CDC childhood immunizations program. So seeing the opportunity of the Reagan administration's budget office saying we're going to cut this program in half and effectively immunize only about half as many kids. Their argument was the states will take up the difference. The states were telling us we don't have any money. So I did put together a hearing, which means first I go to my boss and say we should do a congressional hearing a committee hearing on this topic. He agreed to it. And then I look around and try to find the experts and blue ribbon witnesses to come testify about this, about why it's important. So, and part of the other job for, at least I think, effective congressional staffing is trying to get the press interested as well. So I got a guy who'd won a Nobel Prize for his work on polio vaccines. And he'd also been a practicing physician. And he came to testify in front of my committee, and he brought, there'd be videos now, there were slides and PowerPoints at the time, he brought PowerPoints of people in iron lungs because their whole lives had been ruined polio. And he said, this is what we're gonna go back to, is little kids with braces on their legs for the rest of their lives are totally disabled, the people who can't get out of an iron lung because they no longer able. And then after that, had someone from a state testify that they in no way, a state government, in no way be able to pick up the slack if the CDC didn't pay for this. And then after that, had some people to testify about epidemiology, and this is how it's gonna spread. And by the time that hearing was over, we had press saying Reagan brings back infectious diseases. We had Republican senators who were trying to get out of supporting the president's budget. And then when the legislation comes to pass the budget for that year, we had overwhelming support for childhood immunization on the basis of that hearing, on the basis of the press that was generated afterwards, and then a lot of public interest and advocacy groups came to understand that they might be able to defeat this one, even though Reagan was an incredibly popular president at the time, that you could fight back. So like the American Academy of Pediatrics, the pediatricians, or the Children's Defense Fund, or the PTA. We actually had testimony from the PTA, of all people. They don't usually take part in politics, but we want kids immunized. And so the advocacy groups were going around to other people's offices as well. I counted as, I stumbled into how to do this, but it was a great success. And we defeated the incoming very popular president's budget proposal, even though the Senate was Republican and adopting everything that he wanted on this and a few other issues, we prevailed. So, but that's the beginning of how I started doing this.
I'd like to turn to an issue that not so much was caused by the president, and this Reagan, but emerged during the Reagan presidency, which was HIV/AIDS. And I just so everybody in the room understands the role that Tim played. This book called "And the Band Played On" was the first journalistic sort of description of the beginning of the HIV pandemic. It was published in 1987. So I think, for those of you who've been in other classes with me, what I remind everybody that I knew, everybody I grew up with that got HIV died, 100%. And so I read this book because it provided context. Of course, I grew up as an Irish Catholic kid on the northwest side of Chicago. I didn't know anyone who was outwardly gay. I knew there were, gay neighborhoods in the city. Like, that's as far as I knew. I had no idea of what was happening in communities, literally next door to where I live. Now, in this book, among the many people in the index, Tim is listed more times than Congressman Waxman or President Reagan. And I guess one thing one thing that struck me about the work you did with Congressman Waxman was you all observed a public health issue as it emerged and brought it to, so I guess maybe if you could share a little bit about what it was like in those early days as you all thought about how to respond to something that nobody really understood, at least initially,
Right.
and how to use the process of Congress to bring attention to it.
I'll try. I find it I find it hard. I teach health law at the law school, and I find it sometimes hard to talk to people about the AIDS epidemic because you guys, young people, just assume a sort of baseline belief. Most people baseline belief that gay people have a right to be alive. And when I was doing this stuff, oh, and you know, it's irrelevant to this, but just so you know, I am myself gay. And I was sort of out at the office, but mostly in the way of I brought my partner to staff parties, things like that. But that was it. And some of the right wing, what would be Ted Cruz now, Jesse Helms, people at the time were trying to say that I was working on AIDS because I'm gay. And I said, you know, I'm working on AIDS because it's the leading public health issue in the country at this point. I didn't work on childhood immunization because I was once a child. And I also staff and work on family planning issues, which are total abstraction in my life. I work on public health issues. So, but I have to try to convey to you how easy it was for everybody not just to disregard but actively hate gay men at the time. And if you go online, you'll be able to find Reagan's press. What do we call the guy who's the spokesperson for the White House?
Press secretary.
Press secretary. You'll be able to find Reagan's press secretary with the White House press corps making jokes about how, you know, maybe you're gay, maybe you're the one who's going to get sick. I mean, and you know, the jokes right now, you look at them and say, this is disgusting. But at the time, everybody was laughing. So, I came to know about this disease because it actually fits together after the childhood immunization budget fight and the tuberculosis budget fight and those kinds of things. I went down to Atlanta, where CDC is, to meet the people who were working on these programs so that I could understand them better. They were also the people who taught me the difference between incidence and prevalence, so I came to understand that bit of statistics as well. But I went on there, and I went from sort of program to program, meeting because Washington's a long way from Atlanta politically. And CDC at that time used to get forgotten. It doesn't anymore these days, post-COVID, but or during COVID. But so I went around and I came to understand the programs that I was supposed to work on, defend, improve, whatever it may be. And at the end of it, I met a guy, the CDC director took me and said, there's this guy who's working on a new disease that's showing up in your chairman's district in Los Angeles. Because my boss, my chairman, was from West LA. And so he represented West Hollywood, which was one of those gay ghettos that John was talking about. There were a lot of gay people at the time. And many of the new cases coming out of this unusual disease of pneumonia showing up among young, healthy gay men were showing up in West Hollywood. And he started describing to me, well, we're interviewing people, we're trying to figure out what they have in common. Have they all been exposed to a toxic substance someplace? Do they all take some kind of drug that is prevalent in the gay community, whatever? And I said, well, I'm sure that my boss would want to be helpful if he can. Let me know what we can do. And he said, no. And I said, what? And he said, well, we're barely able to get in and talk to the gay community now. And if we showed up with the Congress behind us during the Reagan administration, nobody's going to talk to us. Because mostly gay men at that time wanted to be left alone. They wanted to be hidden. And I said, okay, but let me know if we can be helpful. And about 6 months, 8 months later, he said, I think we have the confidence of these people. I think the community would. And so we held a hearing not unlike the childhood immunization hearing, but rather than saying, here's a disaster that we know will happen. Here's a mystery, and it seems to be getting worse. And the Reagan administration is not providing enough money to do the public health and biomedical research work that the experts say is needed. And so my lead witness at that one was a young gay man who had been writing in a gay newspaper about his experience from San Francisco, about his experience of having this disease that no one knew about, and his friends were now afraid of him. And he was the first witness. But then I had a CDC the same guy, epidemiologist, testify. Then I had people from the NIH testify, and they all said, we don't know what it is, but the numbers are exploding. And we need to do public health epidemiology research. We need field work. We need to travel and interview people. But we also need a lot of lab sciences, and we don't have any money. And they're not allowed, the civil servants are not allowed to say our budgets are insufficient. The White House says, that's our proposal. You have to defend it. But we could find outside people who would say it's insufficient. And then when the civil servants came, we'd say, the guy who just testified from the American Cancer Society, I don't remember who it was, just said that you don't have nearly enough work going on. Why don't you? And he said, well, we're doing the best we can. Well, would more money help? Well, yes. So you get around and get on the record to say we need some more. But at the same time, the press wouldn't cover it because it was about gay men. And the Congress people wouldn't touch it. So we had to frame it as this is a public health emergency that we don't understand. And we framed it with toxic shock. Do you guys even know what toxic shock syndrome is? It's something that affected women who, for the particular kind of tampon that it grew bacterial cultures, but it exploded as a public health problem. We had to frame it with Legionnaire's disease. We had to frame it as every year there are unexpected emergencies that we need to have a contingency fund for, because we couldn't talk about AIDS because they didn't want to talk about gay men. And we didn't even have drug abuse cases at that point. It was all gay men. So we framed it in general of we have this general problem with the way HHS is budgeted, that every dime is budgeted a year or 2 years in advance, and then if something new shows up, we don't have any ability to respond. And so we talked about it that way to begin with. And then as the numbers for AIDS grew, we started to be having more here. I think I staffed, by the time I left, 35 hearings on AIDS and HIV. And we started to be able to get, really more Nobel Prize type witnesses to be able to come in and say, this is really bad. You need to spend some more money to understand what's going on. It was kind of the exact opposite of how everybody responded to COVID, where everybody said, oh my gosh, we need to drop a lot of money into this right now and do research on it and put $1 billion out there for the pharmaceutical companies to develop a vaccine. In this, they were just saying, we've got what we need. So now we had to find a way to convince people that we didn't have what we need, and to convince them that it mattered, that there was such a public health, such an emerging infectious disease, even though it affected people that they hated. So we tried not to, at first, talk about how it primarily affected, or almost exclusively at the beginning, affected gay men, but talked about it as a general problem. First, even just, it's a budgeting problem, because you can't budget 2 years in advance for what you don't know. There's going to be Legionnaire's disease. There's going to be, now we know, there's going to be COVID. So we started that way and then moved on to starting talking about, and the way that we ultimately got some real progress 10 years later in getting funding for providing healthcare services for people with AIDS was to, and Mr. Kennedy in the Senate really did this, was to point out that emergency rooms were filled with people with AIDS. And people in car crashes or with heart attacks had no place that they could go and get healthcare services in large metropolitan areas. So we needed to figure out some out-of-hospital care programs, grants to provide community care for people with AIDS, rather than having them all have to go to the hospital. And so once again, we sort of veered away from you're not helping those people you don't like. You're helping the community because the hospitals are full and you need to, provide some extra room for everybody else. So that's sort of the strategy. Along the way, I mean, the story in this book is the gay community got organized and started advocating on their own behalf. Um, but it started out, and at the time of that book, it was really all mainly major cities. It was New York, Los Angeles, San Francisco, Miami. And so in the Congress, in the House, there are a lot of people who come from those cities. In the Senate, you've got people from Wyoming who say, why do I care? And you have a lot of people from rural parts of even the states with big cities saying, why do I care, Mike? So, we had to work around that. But the gay community started getting organized and demonstrating. And, I don't want to say, I'm going to say some of them were very good friends of mine who were AIDS advocates in black T-shirts and 3 piercings, and I was there in a little blue blazer with a tie. And we worked together. It was their job to get attention and to scream out and to lie down in front of the White House or hold a mock funeral in front of the White House with a casket, or pour blood on the steps of the Food and Drug Administration. It was my job to say, okay, if you can't, let's negotiate here. If you can give on 1, 3, and 5, I can give on 2, 4, and 6. Let's try to draft it in a way that actually, so they were outsiders, I was an insider, and we managed to find ways of working together on this. And a few people sort of picked on me because they knew I was gay, but not many. Ultimately, it became a big enough issue that it affected not just the 5 major metropolitan areas that had big gay ghettos in them, but also it started spreading. And I actually think, I'm going off topic a little bit here, I think some of the progress was in AIDS and then later in gay and lesbian LGBTQ civil rights, is that a lot of people who didn't think they knew anybody who was gay suddenly discovered, because people were getting sick and dying, that they did indeed know people who were gay, and that they lived in smaller communities. They lived in Louisville, Kentucky, and Memphis, Tennessee. They didn't all just live in San Francisco and New York. And also at that time, a lot of people went home to die. So I think in some way, the pervasiveness of the epidemic convinced the Congress that it started being clear that there were people in the politicians, in my view, are very rarely simply altruistic. They do things because they think it helps their district or their constituency or their state. And convincing somebody from Utah that this is going to help in their home state is not easy. But if people start going home to die, then it does. So
I think really good politicians at their best listen well. And they're not, again, on any given day, there aren't 535 excellent politicians. But I've met people from very conservative places who listen.
yeah,
And they will listen because they hear the people are coming home to die. They see that doesn't mean they're going to wake up and have a change of heart on sort of big picture public issues, but the way in which an issue emerges changes. I mean, I worked for a Southern Democratic senator. If we issued a press release on HIV or LGBTQ issues during his tenure, I don't recall it. Was he helpful in things because we were involved with people in our community who were directly impacted? Absolutely. I'm very proud of it. It's a different way. I just think when politicians are at their best, they can hear and listen to things and then shape their response. And I think helping them do that is part of what good staff work does.
and I think, especially in circumstances like then, and to some extent now, coming at the problem sideways is more likely to succeed in the Congress and with politicians than a face head-on confrontation with. instead of saying to I can remember working against an amendment that was going to be testing everybody in the prisons for HIV and then isolating them and all that. And I can remember working with a conservative Midwestern Democrat um, that we were trying to convince to vote with us, and having him say, and I can't even convey to you how inflammatory this language was at the time. It probably sounds normal to you. But halfway through my explaining this to him, he said, "This isn't about queers, is it? Because I don't like queers." And I was just, "No, sir. It's about the best allocation of limited resources in the penal health system. And we don't have enough money to do all of this, so why don't we follow what the prison health people are recommending?" And he was with me at that point. If I'd tried to convince him that he actually liked gay men, I could have ended the meeting right then. But if I say this is about allocating limited resources within the prison system, he was ready, and he voted yes.
Well, before we turn over to so getting ready, Colin, and is maybe maybe the ultimate sideways legislative achievement of our time, the Affordable Care Act. And again, everyone here had to read the Cohen article, so they have a little bit of a sense of the drama. But I guess, and I think we could spend hours talking about the Affordable
I
Care Act.
have.
Exactly. But maybe a few reflections. We've talked a little bit about, how how a committee and a staff help fight bad policy proposals from an administration. How you surface an issue that's emerging. But how actually building something anew, a new health insurance system in the country, is a big deal. And I guess just some reflections you have, because now, we've got I think the Affordable Care Act is as secure as it's going to be. Yes. But looking ahead, if you're trying to think about further expansions or how to strengthen the system, some reflections you have before we turn it over to questions about what you learned from the ACA process and from where you sat, because you were drafting key provisions.
Well, I would contrast it with the time that you and I wasted working on Clinton health reform,
Yes.
where I wasted 2.5 years of my life on that, and I don't know how long you wasted, but a lot.
A lot. Yeah.
And what happened at that point in Clinton health reform was we went from a time during the election of Bill Clinton when something like 3 out of 4 Americans said that they were in favor of health reform and expanding to national health insurance, to by the time the votes were taken a year later, we had 3 out of 4 Americans saying they were opposed to Clinton health reform. And what happened during that time, I believe, is that the industry, the health insurers, the hospitals, the pharmaceutical industry, the various people who were making a lot of money off of health care the way it was, convinced people overtly, the public, you're going to lose what you have. They're going to take it away from you. They're going to make it bad. And enough people had health insurance through their jobs or through Medicare that they were afraid that they were going to lose it. And it would become watered down or taken away altogether. And the advertising was overt. I mean, John can give you links about this, saying, the Bill and Hillary Clinton are just going to take away the American way of health care. And it collapsed. By the time we got to the Obama proposals, we were coming out of the 2007, 2008 recession. Great Recession, I think they call it still.
Yes.
And the public already knew they could lose what they had. Because since we are uniquely, as you guys doing global health will certainly be able to attest, since we are uniquely a system that associates health insurance with your employment, you lose your job, you lose your health insurance. So you go into a really bad recession like 2007, 2008, a lot of people lose their job, they lose their health insurance, the Medicaid programs are really skinny in their home states, and suddenly people are afraid they're going to lose what they've got if they don't do something. And the word that that I use with my students is a sense of precariousness. That, and the Clinton health reform tried to it was called the Health Security Act, for crying out loud, tried to convince people this is what you need. But by that time, people had seen that the commercial health insurance market was not going to take care of them. And I think that that was the crucial difference between Clinton health reform and Obama health reform, is that the public came to believe that the system wasn't going to keep going the way, taking care of them. And the other thing that happened that the Obama administration and officials in Obama realized was they had to work more cooperatively, not confrontationally, with the people who were making a lot of money out of the current system. So there's a mandate to buy health insurance. Well, the insurance companies loved it. So there was, my boss hated it. I think it was a mistake, but the Obama administration agreed that they wouldn't do any pharmaceutical price controls. So the pharmaceutical company was okay with it. And the hospital industry, they were already dealing with a whole lot of people who didn't have health insurance and having to take care of them. So this looked like it might be better, that they'd get some people into insurance that didn't have it, and there wouldn't be as many bad debts and bankruptcies. So the industry started to coalesce in favor of this in a way that they had all opposed it during the Clinton administration. There was this one-liner, I don't know if it's in the Cohen article or not, but that people really did say from the industry side of, you need to be at the table or you're on the menu. Because we needed to find money to cross-subsidize all the new things that we were doing. So the two things are the public attitude of precariousness and the vested interests' willingness to cooperate, and then trying to get the Democrats not to shoot each other, which Democrats are very good at doing, and then making some very difficult compromises along the way. I mentioned, I think, on the way that I used to staff reproductive health issues and family planning. And we almost lost the entirety of health reform over abortion debates. And I was in a conference where Ms. Pelosi and some of the senior Democratic women were just saying, we're going to have to vote no on this, except, of course, Pelosi couldn't. She was trying to, but we almost lost the entire bill, and we ended up giving up, not as much as the Supreme Court has, but giving up a lot of access to abortion services in the Affordable Care Act in order to get enough anti-abortion Democrats to support the package. And that was an extremely difficult compromise for Pelosi and Louise Slaughter and a lot of these women members, not just women, my boss was in the group too, who had spent so much of their lives trying to defend a woman's right to contraception and a woman's right to reproductive health, and then have to compromise in order to get enough votes to be able to provide health care to everybody else. So, difficult compromises there, but I do believe having the industry come together and having the public sense that they were going to lose what they had. Does that make sense?
Absolutely. No, I think that is exactly where we should turn it to the students. So, Colin, I'm going to start with you. If you would kick us off.
And you can be blunt. I like arguing. So.
Well, I was just curious if you experienced a learning process for the fact that it was better to repackage problems in a way that were more digestible to the people we were trying to convince, or if you had known that before going in.
Oh no, I didn't know it going in. I really didn't know it going in. Do you guys know what ACT UP is? The AIDS advocacy group, really confrontational, black T-shirts, 3 earrings, dying in front of the White House kind of thing, and me in my little blue blazer. I remember these same AIDS protesters were sitting in my boss's office in Los Angeles, and I was just kind of, what more do you want? What can I do? And they were holding protests in front of Nancy Pelosi's office, and she was representing San Francisco, and finally I remember a conversation in which we were talking about giving people who use drugs access to clean needles so that they could continue. We're opposed to drug use. We know that, but we also know they're not going to quit on their own. Let's at least make sure they don't die from HIV from doing this. And the AIDS advocates were saying, we've got to have a vote on clean needles. And I said, look, we'll schedule a vote tomorrow if you can show me that I've got a simple majority of my subcommittee. We're going to lose. And if we lose in public, it's going to be worse the next time we try to talk about this. Or if we lose in the Congress, then they're not even going to be able to talk about this in New York and Los Angeles because it'll be like, see. So my experience was if you confront without the votes, if you don't have a simple majority, then you got to make a compromise. And there were a lot of times, I mean, Pelosi on the abortion provisions of the ACA, I don't mean to make grand, but, compromises on condoms and clean needles and blunt AIDS education material. I made lots of compromises that I knew were not the best policy, but they were as good as I could get with the members of the committee that I had at that point, or members of the Congress that I had. And, I finally just said to this guy, who's featured pretty prominently in that book, being angry is not enough. I need a simple majority of the committee, please. I need half plus one, and you're not delivering me anybody new. So I learned this along the way. And I guess if I can go all the way back, a sort of different, the very first piece of legislation I worked on for a year and a half under the Carter administration, I go back that long, was to First Lady Rosalind Carter's initiative was to rewrite community mental health laws to try to provide more services in the community. And I worked for a year and a half on that. And then Reagan came into, and we succeeded, we got it through, signing ceremony, White House, all that kind of stuff. And then the Reagan administration came, and I got to draft the paragraph repealing it. So I'd written 70 pages over a year and a half, and then I had to repeal it. It was my job then to write the language to repeal. So I had a sort of Sisyphean, clear understanding that if you don't have a simple majority, it's not going to work. So I became somebody angrily described me as ruthlessly pragmatic one time. And I said, yeah, I think that's my job description. I'm ruthlessly pragmatic. That's what it is to work in politics on health. Is that responsive?
Yes, thank you.
Sylvie?
Yeah, because our class is Conversations in Health, Global to Local, we've been talking in our global health class about how much money the U.S. spends on healthcare, especially compared to other high-income countries, and kind of the disparity between that and then the actual health statistics, the epidemiology of our maternal fetal mortality rate and our life expectancy and everything, which should be a lot higher than it is. So the Affordable Care Act has definitely made a lot of jumps in providing more care and kind of bridging that gap a little bit, but do you think that there are policy directions that we should focus on in the coming years to bridge that gap even more and put our money, I guess, where it should be going?
Domestically, or are you talking about globally?
Domestically.
Yeah. I should have said at the opening in a disclaimer, I've spent my career working on domestic issues. I know a lot of people who work on global health. Some of them are very good friends of mine, but I don't know or understand global law or global institutions.
It's a different time, but
Yeah.
But you know plenty about how to make the U.S. healthcare system achieve better resources.
I mean, your question already implies the answer, which is we spend way too much money on healthcare services in the U.S. And we don't get back. I mean, you look at the data for infant mortality or life expectancy, and a lot of it is deeply driven by class and race, because we spend a whole lot more on affluent people than we do on, and I used to run the Medicaid program, so I know about it. And Medicaid is, believe it or not, underfunded. Private health insurance, I think, is overfunded, not in the way that people are getting way too many benefits, but we pay too much for the benefits that they get. But going back to, the collapse of the Clinton health reform, if you talk about taking away something that people actually have now or feel like they're under the illusion that they have now, you encounter a whole lot more resistance than if you try to provide services to other people without doing that. But that sort of that hydraulic of we're spending too much, we need to spend it over here, well, that sort of necessarily means that you need to spend less somehow on the people who have health insurance. And I believe we can do that by purchasing more prudently. I do not understand why we don't have drug price controls in this country. I mean, I know I can answer the politics of it, but I can't explain to you how people justify it to themselves at night. And the other thing is that I think a whole lot of the services that we really need to reduce our overall health bill are not individual services, but public services, community health programs and public health programs. Not all of them save money. I don't want to be heard to say that. If you take a health economics course, you're going to find very quickly that a lot of these things cost money, but they produce an overall lower health care bill for some groups, and they improve infant mortality and things like that. So, but our system is rigged in some way for, I don't mean to say rigged, skewed in some fashion to prize much more providing individual health services than for the community at large. So, well, the one I always end up using is lead-based paint and lead poisoning. And, Medicaid pays for screening kids for lead poisoning and for getting the lead out of their blood, chelation therapy, that kind of thing. But Medicaid doesn't pay for getting rid of the lead in public housing or getting rid of the lead dust that's around. And so our system is skewed towards responding to individuals rather than going upstream quite a bit and trying to remove the problems. So if we could do that, we wouldn't have to pay for as many disabled kids with lead poisoning. I mean, it's just immoral. I mean, lead poisoning should have died in the 18th century, at least the 19th. I mean, some people would say it should have died during the Roman Empire, but it certainly shouldn't be around in the 21st century. We know everything to do, and it's affordable, especially when you contrast it with how much we end up paying for disabled kids and adults. So population-based services, community programs, those kinds of things. And then the dangers of having pharmaceutical companies convince people who have health insurance that they're going to lose what they have. When in fact, many of these new drugs just don't provide added benefit for health and certainly not added longevity. So there. And did I rattle on enough for that?
That was great, thank you.
Sure. Thanks, Tom. That's good. So why don't we just work around this way, Arjun?
Yeah, so thank you so much for speaking. I found it really interesting. And one of the things that really I found resonating was in terms of your expertise in the Medicaid program, one of the things I find most interesting about the Affordable Care Act is the Medicaid expansion provision. And I know during COVID and now in this post-COVID era, we've had a couple of states who have tried to pass Medicaid expansion.
Yep.
And I was wondering if you could kind of talk about your experience and how that provision was passed and where you see Medicaid expansion going.
Well, I wish I could take credit. I didn't actually staff the Medicaid legislative provisions. The guy whose desk was next to mine did that. And he's actually on the faculty at Georgetown, the Georgetown Public Policy School. His name's Andy Schneider. And he has worked his entire life on trying to expand Medicaid. He's the reason that Medicaid actually expanded to cover all pregnant women and kids. And he did, while I was doing HIV stuff over there, he was incrementally expanding the mandatory Medicaid eligibility. But he staffed the provisions in the ACA. The problem with expanding it in the ACA to be universal, I mean, I don't mean to get too legalistic about it, but if we'd ended up paying for it all with federal funds, instead of asking the states to continue paying for half of Medicaid one way or another, I don't think the Supreme Court challenge would have held, and I think that we would have a universal Medicaid program now. But we didn't have enough cash. I also staffed budget issues in the ACA. We didn't have enough money to spend. Mr. Obama had unilaterally said that the total bill of this was not going to be more than $1 trillion. Even if we raised taxes, even if we cut Medicare, the bottom line couldn't spend more than $1 trillion, so we didn't. And then there were also the states who were saying, you know, we can't absorb the matching costs of this. So that was how we ended up with the compromises. They were budget driven, that there wasn't enough money to pay. And then there were also, there were some Democrats who continued to believe states should pay for some of this. That's the nature of the Medicaid program. It's why it's different than Medicare. I don't understand that argument, but they do say it. But we had to continue Medicaid as a federal state matching program, and that in turn led to states opposing the mandate that they expand, and taking it. 26 attorneys general ended up in front of the Supreme Court saying it's too much, and we lost it. These sort of from the grassroots up Medicaid expansion things are astonishing to me to watch in some of the states that they're coming in from. I have family in Montana, and you know, Montana is not open to socialized health care, but they are recognizing that the hospitals are underfunded, and hospitals make money off of Medicaid. If you've got two patients sitting there, one of them is altogether uninsured and the other one has got Medicaid, you know, Medicaid doesn't pay as well as Blue Cross, but it pays better than nothing. And the hospital associations and, you know, the physicians groups who are taking care of uninsured people, they recognize this. And then there have been business school studies of how states actually end up through the economics of multiplication. What's the multiplier effect? So the multiplier effect in bringing more money into the state than it can be used, and you know, the newly hired nurses will spend money at Walmart or something like that, and you end up getting more for the whole state. And that's convincing some legislators, but mostly I think it's people recognizing that having a lot of uninsured people around costs the society money. And I have been astonished at some of the states that have been able to do it that way. Now, I was astonished when the Supreme Court ruled against the Medicaid expansion too. You didn't give them my article about that.
I didn't.
That said the Supreme Court's surprising Medicaid decision. No one, and I mean no one, expected that Supreme Court decision. But I think ultimately that we will end up with state legislators recognizing that it's not in the state's economic interest to have a whole lot of uninsured people around.
I think for a lot of the states that are still holdouts, it's going to take the process of a deep politicizing. The more time there is, the more voters see the precarity of your earlier point, the more interests point out the benefit of expansion, and the more distance those states can find themselves, or those legislators can find themselves from what they thought would be supporting Obamacare, and instead be supporting fill-in-the-blank care, or this solves a problem in my. The ideal is I'm voting for this to keep this hospital open in my district. That's where you want to go. I did a little bit of work with state legislators on previous Medicaid, and that's where you want to be, in places where you otherwise, if you had an up-down vote on expanding federal programs, you might not do so well.
And that's sort of approaching it sideways, what I was saying before, of I'd be perfectly willing to go out and say, I'm a Southern preacher's kid, you should take care of the poor. And I wouldn't get the votes. But if I could go in and say, you know, this is a good economic investment because it'll keep this hospital open, and then there'll be a multiplier effect that will bring more business into the state. I'm perfectly happy to approach it from that way. And the end result is you should provide health care for the poor. So, is that responsive?
Yes, yeah,
Huh.
thank you so much.
Sure.
Yeah, did you have your hand up?
Oh yeah, I just was interested because, like, as you mentioned, America has like a uniquely individualistic approach when it comes to like healthcare issues, and like in terms of like health insurance and like, as you said, focusing on health issues only when it affects you personally. I was just wondering, like, what your thoughts on, like, are there any ways we can challenge like this ideology in America, like through the government, or is it kind of like set in stone
Is
and
it
not
sort of
really
baked
changed?
in? Well, I have to say, I was astonished at how many people didn't want to comply with COVID prevention measures, even though they knew it would result in increased illness and death among elderly and disabled people and people with a lot of special conditions. You know, it just seemed altogether un-American to me to say, and I use that advisedly, un-American to say, I'd rather not wear a mask and let my grandmother die. I mean, but it is that. And I think the only way that we're going to, again, approaching this sideways, I think people are not, and that demonstrates it, very altruistic. But if you can demonstrate to people that it will be good for them in some way, then but that isn't getting at the heart of the individualism that you're describing. It's instead trying to broaden the understanding of what is your personal good. So one of the things I think that helps is to say, you know, you're going to avoid a recession if we have a less severe pandemic, and people won't lose their, or if you can say it's cheaper to give people a vaccine for polio than it is to have disabled children living their lives in a rehab hospital. But you know, that's not what I'm projecting onto your question, and tell me if I'm getting it wrong, is can we make people think differently about it as opposed to vote differently? And I don't know, I sort of feel like COVID has shown us that people are getting more and more individualistic and self-centered about health than before. I'm not sure if we had that same childhood immunization hearing again now, that we wouldn't have people opposing it right in the middle of the, and I'm telling you, everybody was just saluting the idea of getting more kids polio vaccine. And it was just, so I'm not sure that we will be able, not in my lifetime, I don't think, be able to get people to be less what you call individualistic and what I'm prepared to call self-centered about access to healthcare. Okay, John, you?
I'm not optimistic about that change. I think the cultural change that you're talking about is pretty fundamental. I guess the optimistic side, if there is one, is that I think one of the challenges of COVID was things got put in a partisan box, which actually exacerbated the problem of individuality. I think there are ways to take some health issues and try to skirt, frankly, the blue-red team jersey setup. I think if once your issue falls into the blue-red team, it's like like Obamacare. It was, it almost was brought down without a replacement because it moved into the blue-red jersey mode. Thankfully, that didn't happen. Hopefully, future issues people can find a way to avoid them getting, because once they're in that spot, then people are just going to react negatively. And they're going to want the government not to be in their lives, unfortunately. But let me say this, Jim? Because Abby, I couldn't tell you.
No.
Jim, please.
Okay, Professor, I was just wondering if you could talk a little more generally about the field of health law, since this is something I'm particularly interested in. Like, as you mentioned, there's a set of law that protects people who can afford malpractice suits, like malpractice. There's also IP law for pharmaceuticals, and I guess, like, states' rights for, like, if the Supreme Court wants to overturn a piece of like an existing, like,
Right.
Roe v. Wade. And, like, how exactly can health, or, like, the U.S. legal system used to protect people and their health?
Boy. Just some more water. Well, as you say,
When I did health law, there wasn't a field of health law. Now there are 25 fields of health law. Intellectual property protections for tech and pharmaceuticals. And, you can make not just an entire career, you can have an entire law firm on the basis of those now. Reimbursement issues, trying to figure out how to categorize things for insurance companies or Medicare and say, it's this disease and it's severe enough by this. Those kinds of reimbursement issues occupy several law firms in this town now. When I was in law school, nobody was doing this full-time as a lawyer. Just choosing that I'm interested in health law is not enough for one of my students. They then have to, I ask them, are you mostly interested in public health and community health? Or are you mostly interested in individual health? Are you mostly interested in innovation and intellectual property? Or are you mostly interested in how money is distributed around in the system? And then, of course, there's the constitutional and individual rights issues. There are the federalism issues of who's in charge with this. There are 25 fields of health law there. I don't know that I'm responding to your question. Are you asking me something different than that?
Oh, no, sorry, it was a very general question. I really appreciate the response. I was just wondering more or less, are there any, existing, policies that, protect people? Say someone...
individuals?
Say someone can't afford, insulin or something, or needs to skip, or, ration their medication.
Right.
How can the law help these people?
Oh, so, I'm sorry, I did misunderstand the question, I apologize.
Well, it's the first two classes of my access to healthcare law class for the semester, but the long and the short of it is there is no right to healthcare in the U.S. There are in a lot of other countries, as I'm sure the global students here could say, or the person from Britain could probably point out too. But in the sort of example that always gets used in health law classes is if you're in Europe, Brexit doesn't count Britain in this, but yes, if you're in Britain too, and no, it doesn't. If you're in continental Europe and you walk by a lake and you see somebody drowning, the law requires you to try to lend assistance in the best way that you can, in general. There's a duty to help in European law as part of most countries' fundamental. In Anglo-American law, from the beginning, certainly from the beginning of the U.S., but it's embedded in English law too. There's no duty to help. You can walk by and ignore. I mean, there can be a rope lying there that you could throw or a life preserver and you just walk by it. There's no legal consequence for that in Anglo-American law. So it's completely different. And yet at the same time, most of my students respond with, that's immoral. And I'd say, I'm telling you, there isn't a right to health care. What's more, there's not a duty for doctors or hospitals or pharmaceutical companies to provide services. You can be licensed in order to provide services, but there's no legal duty to provide them. So some states, by universal access to Medicaid, give people some rights to, if you have a Medicaid card, you can be guaranteed to get certain basic services. But not all states do that, obviously. And practically the only thing that is a legal right that you have in the U.S. to get access to health care is there's a statute that requires hospitals to screen and stabilize somebody who comes into the emergency room without asking whether they can pay for it. But the statute isn't a command on the hospitals. It's a condition of the hospitals getting Medicare payments for everything else. And Medicare is such a huge program that almost every hospital participates in that it functions essentially as a requirement on the hospitals that everybody who walks into a hospital and says, I'm experiencing a medical emergency, they get screening and they get stabilization. But they only get that. So if they screen you and say, okay, you were having an attack because you've actually got brain cancer, they don't have any duty to do anything about your cancer. Nothing. They can just discharge you as long as you're stable. But that one thing is a right, and it's a right because hospitals want to be paid by Medicare. Does that make sense? It's called EMTALA. You're going to run into it sooner or later if you do it. The Emergency Medical Treatment and Active Labor Act. It also requires them to screen and stabilize pregnant women who are in labor. And that was a fight, believe it or not. So, but that's the one thing that I can point at and say there's a universal national right to, is screening and stabilization. Although if you go to a hospital that doesn't take Medicare, and there are only a few, but like children's hospitals oftentimes don't take Medicare because they don't have it, they don't have to do that. So. Oh, and one other thing, there are a lot of charity hospitals or public hospitals that have as part of their mission to provide healthcare services. That's not a legal right. It's just, their mission.
Two more here, please. Go ahead.
I was kind of more interested in learning like more about what a health law career would really look like. So my question is like, what's kind of one thing that you found most interesting or like most unique through all the projects that you've worked on?
Well, I've got to find a common thread in all of this random stuff that I. Think about that. I don't mean to get all evangelical about it, but I do believe that the most interesting thing that I've worked on in public health and in health insurance and Medicaid kind of side is trying to figure out how to spread access around so that people can have a basic minimum. It's going back to your question, is there a way of incorporating into legal programs, maybe not a right, but an opportunity for everybody to get something? I believe in distributional ethics like that. And I remember the tuberculosis hospital patients. I still think of them. And it was easy to apply that to AIDS and HIV. It's easy to apply that to Medicaid. It's easy to apply that to the Affordable Care Act. So I guess my common thread, if I have to have one, and I'm telling you most of it was random how I ended up in these places, my common thread would be improving distribution of minimum service, of at least basic services, either through a community base or through more access to individual health insurance. That responsive?
Yes, thank you.
Sure.
Please.
Sorry. I know you spoke about several times about the going at something sideways, and especially with HIV, how you would talk about the issues being with the prison systems or support for lobbying because of the hospital system or something. But obviously, it did have to do with a very important social issue
Social
in the
justice.
world, and so even though you were coming at it as a radical
Pragmatist.
yes. How was your awareness of the effect that your policies had on society at large? How did that influence how you went about your day-to-day
My sideways.
career?
It is possible to get caught up in deal making and compromise and lose sight of the goal. And I know people whom I've worked with on the Hill who want more to succeed with getting credit or getting a legislative success than getting a policy that actually ends up accomplishing the goal that many of the people who come at it sideways and keep going after they got where they wanted to go. Legislate bills in the House and the Senate. The House bills are numbered HR, House of Representatives. Senate bills are numbered S. I was in a House Senate conference one time with a staff director who took me out in the hall and said, one-on-one, not talking with his staff, you can write anything you want. I don't care what you put in there, as long as it starts with an S. As long as my boss gets credit for having succeeded at this legislation. You seem to know what you're talking about. Go ahead and write what you want, and my staff will put an S on the front of it and we'll pass it. That would be wrong. And in turn, I have great loyalty and reverence for my former boss. But we were in a gigantic National Institutes of Health piece of legislation. I mean, it was several hundred pages long, and all kinds of staff people were working on it too. But the thing that I was working on was fetal tissue transplantation, which is sort of the precursor for stem cells and things like that. And the anti-abortion members were trying to get, and I called him at home, late at night, my boss, and said, the best that Bruce and I can do in this instance is this compromise, and it's really going to limit what the research scientists can do. But there are all these people out here who have come to complete agreement on 300 pages of compromises of the policies that they want. And he said, you know my conscience. And I killed it. I pulled the plug on the bill. And I had a lot of staff people who were mad at me because I said, he can't agree to this because it's going to. So we ended up putting the fragments back together again, but we dropped out the provision that I wanted and the provision that the opponents wanted about fetal tissue transplantation. And, but I did walk into the room and said, we're walking, he's going to kill the bill. So that's. Conscience matters a lot at some of this stuff. So, but again, I know I'm sounding cynical, but I still don't believe most politicians do things out of total generosity or altruism. I do think that pragmatism and coming at it sideways is the way of getting. Now, that is to say that a lot of advocates and activists have to be there so that the radical pragmatists among us can actually move forward and say, well, we need to fix this because look how bad it is. We just have different jobs. And I was more comfortable in a blue blazer and a button-down shirt than I would have been out on the street. So
But the inside-outside game is different. It just means you're playing different roles.
yeah.
But with both of them, there's a conscience issue. You always have to know where your line is. And some people, I do think, forget.
Yeah.
But that's the challenge. So I think, did you have anything cool? So one final question, then we'll go.
First, I just wanted to say that I really appreciated hearing your educational and career journey because I think that I'm going to have a similarly unconventional or flexible journey because I don't really have any interest in the normal med school, lab research, or even practicing law. So I really appreciated hearing that it can all work out and you can be successful and still do good. So my question was, I don't really know as much about the Affordable Care Act as I think I should. But I was just wondering, since you talk so much about having to compromise and sacrifice, I know that there's so much that you probably would want to add to the Affordable Care Act, but is there anything in it right now that you wish you could take out?
It's a good question. It's a great question.
It's a great question.
Does anything come immediate?
Well, yeah, because originally it had so many, there's a whole set of things that are sort of incoherent about the way it's written.
I can justify that.
For good reason, for the reasons you guys know. It didn't happen through the traditional process. But I can't, at this point, there's nothing that I would say is so terrible that it should be a priority to remove. I'm sure there's a million little things that should be changed. I guess I wish we'd handled Medicaid, but
Yeah.
who would have thought?
Who would have thought?
We did a whole project before the Affordable Care Act looking at likely constitutional issues that would come up, and we kind of put that one to the side. And
It's
then,
a Nah, they'll never do that.
There's no way they'll go there.
Um, Well, there is a challenge going on that's percolating up, and I think it's actually been argued in the Supreme Court already now, that I don't know if you know this or not, but in the ACA, people get access, beneficiaries get access to preventive health services without any cost sharing. So you don't have to pay to get a vaccine or to get a mammogram or whatever. The insurance company gives it to you because we didn't want any further disincentives for people to do preventive health, because people don't like going to the doctor most of the time anyway. So don't put any things that they can rationalize not doing it with. And we assigned the responsibility for deciding which things would get that categorization as an accepted and important public health, preventive health benefit, which insurance companies would then be required to provide without cost sharing. We assigned it to a blue ribbon panel of experts, rather than the Congress trying to do it itself. Gosh, please don't let the Congress do it. And rather than assign it to the administration to do, because, what would the Trump administration have said for minimum benefits if you had assigned it to them? We had a blue ribbon committee for both vaccines and preventive health services. And the committee is made up of outside experts who are not federal employees. And we did that on purpose, saying you guys are the best, most likely to be objective and not affected by the winds of politics that are going on right now. And it's gone all the way to the Supreme Court that assigning it to non-government employees who are not subject to the president firing them is in fact over-delegating outside of the government and unconstitutional. And so there is extreme opponents of the ACA are arguing that the entirety of both that benefit, but maybe the entirety of the ACA, should fall because of who makes the decision of which vaccines should be offered and which preventive services like mammograms should be offered. Looking back on it, I wish I had added, and I drafted a lot of this stuff, I wish I had added the Secretary of HHS will ratify this, which is all it would have taken to fix it. We wouldn't have gotten there. But who would have ever dreamed that somebody could litigate that the blue ribbon panel of the Advisory Committee on Immunization Practices was an unconstitutional overdelegation of authority? I mean, no. I mean, somebody had to sit for years to figure out that stupid argument. But I wish I had had a crystal ball and known that if I just had a sentence that said, the Secretary of HHS shall ratify these decisions, it would have been fixed. Now, that's not taking something out, but it's adding something in that I wish I'd had any idea would be necessary. Sure.
What I'd like to do is ask everybody to join me in a round of applause for Professor Emeritus.
Thank you. It's my pleasure. If you think that there's something I could do or others more personal questions about how to pursue a career in health law or something like that, my email at Georgetown is still live, even though I'm not teaching these days. So you can drop me a note. Just be sure and put in there how we've come to know each other, that you were in John's class. And I'd be glad to.
Tim, thank you.
Thank you.
Thanks, everybody.